Welcome to the narrated presentation titled Treatment and Management of the Resident with a Suspected Respiratory Tract Infection. Today we will be talking through several common scenarios in long-term care in order to understand the approach to pneumonia in residents of long-term care settings. We will discuss empiric treatment options as well as different opportunities that may occur in your care process where you can de-escalate therapy using the results of diagnostic tests. Finally, we will review appropriate durations of antibiotic therapy. Here we have an alphabet soup of terms or acronyms. CAP or CAP stands for Community-Acquired Pneumonia. This term refers to people without recent exposure to health care or to broad-spectrum antibiotics in the previous 90 days. HAP or HAP stands for hospital-acquired pneumonia, or any pneumonia that develops at least 48 hours following hospitalization. VAP or VAP stands for ventilator-associated pneumonia, or any pneumonia that develops at least 48 hours after intubation. A notable gap in our current understanding is whether pneumonia in a long-term care resident is more likely to be due to resistant bacteria. We suggest that most residents will have had some antibiotic exposure, making pneumonia in this population more likely to be caused by resistant bacteria and more likely to fit into the definition of hospital-acquired pneumonia. This is an evolving topic, and more rigorous studies are needed to improve our understanding of pneumonia among long-term care residents. Let's walk through our first case. Mary is a 90-year-old resident with mild dementia. She was recently treated for suspected urinary tract infection, or UTI, with a 5-day course of nitrofurantoin. She is typically active and functional in her activities of daily living and has never had a problem with swallowing or aspiration. Her nurse notices that she has developed a cough and her temperature is 99.2. The nurse notifies the healthcare team about her condition after getting vital signs and assessing the resident. The nurse notes that she has a temperature elevation and a few crackles at the base of her left lung. The team decides to get some lab work and a chest x-ray. She has an elevated white blood cell count at 11.2 thousand, and her chest x-ray shows an infiltrate in the left lower lobe. Let's return to our 4 moments of antibiotic therapy. Remember that the first thing to consider is whether the resident actually has an infection that requires antibiotics. In this case, Mary has an elevated temperature, a new cough, leukocytosis, and evidence of an infiltrate on her chest x-ray. She has had no witnessed aspiration events and is not a known aspiration risk. Remember the differentiation between bronchitis and pneumonia. It is often difficult but important to differentiate these two syndromes, particularly because bronchitis rarely warrants antibiotic therapy and pneumonia almost always does. Residents with pneumonia will have evidence of an infiltrate on their chest x-ray and typically have leukocytosis. Now consider Mary's case. She has a cough, elevated temperature, sputum production, leukocytosis, and an infiltrate on her chest x-ray. This sounds like pneumonia and should probably be treated with antibiotics in addition to supportive care. Now that we have determined that Mary likely has an infection that requires antibiotics, let's consider our second moment of antibiotic prescribing. Has the healthcare team ordered appropriate cultures, and what empiric therapy should be initiated while waiting for those cultures to return? We recommend several diagnostic tests to evaluate residents in whom we suspect a respiratory tract infection. Sputum culture and gram stain, if it can be obtained, is recommended to aid in tailoring antibiotic therapy to target the correct organism. Remember from our microbiological culture collection module that it helps to obtain early morning specimens and prompt the resident to cough up deep sputum from their lungs rather than just spitting into a cup. Blood cultures are recommended for patients with a fever and who appear very ill. A respiratory viral panel, if it is available, is helpful to evaluate for alternative causes of symptoms. Viral infections often mimic pneumonia. In fact, a recent population-based surveillance study showed that rhinovirus was the most common cause of community-acquired pneumonia in patients presenting to the emergency department. While respiratory viral panels are not always available in long-term care, all facilities should have a rapid flu swab available. These should be done on all residents with a cough and fever during influenza season, which may start as early as October and extend as late as April. Last, you can consider a urine streptococcus pneumoniae or pneumococcal antigen or Legionella urinary antigen. These are rapid tests with a short turnaround time, and both can help to tailor antibiotic therapy to the causative organism. A few more words on urinary antigen tests. These are not always available in long-term care, but consider working with the contracted laboratory to make them available. If one of these tests turns positive, it will help to diagnose exactly what is going on with the resident. The pneumococcal antigen looks specifically for the organism that is a common cause of community-acquired pneumonia. If the urinary antigen is positive for pneumococcal infection, you can potentially narrow your resident to penicillin alone for treatment, which has fewer side effects than more broad-spectrum antibiotics. For residents with suspected pneumonia without a known causative organism, we recommend the following. Residents who can tolerate oral therapy can be given the combination of a beta-lactam antibiotic, which are antibiotics that include the penicillin or cephalosporin class, and a macrolide or doxycycline. This provides empiric coverage of the likely bacterial organisms that could be involved. If the resident cannot take oral therapy, you can use ampicillin sulbactam, which is a close relative in intravenous or IV form of amoxicillin clavulanate or ceftriaxone combined with IV azithromycin. If the resident has a severe penicillin allergy, we recommend a respiratory fluoroquinolone such as moxifloxacin or levofloxacin. Because fluoroquinolones have a high risk of Clostridioides difficile or C. diff infection and high resistance rates, we suggest reserving the use of this class for only truly severely penicillin allergic patients. Remember that many people with penicillin allergies can tolerate cephalosporins and can receive ceftriaxone. It's helpful to determine if a penicillin allergic resident has tolerated a cephalosporin in the past. Another note here, remember to determine if listed penicillin allergies are real. Up to 80% of the time, listed penicillin allergies are not true allergies, and eliminating these from a resident's allergy list can open up options for targeted therapy and can be helpful to your stewardship program. Let's get back to our case. The provider on call overnight forgets the recommended guidelines. When he hears about Mary's suspected pneumonia, he starts her on a 10-day course of levofloxacin, even though she is not allergic to penicillin. Fortunately, her daytime provider remembered to send a flu swab and urine pneumococcal and Legionella antigens. These are pending at the moment, and we will discuss them later. We made it to moment 3. What duration of antibiotic therapy is needed for the resident's diagnosis? Let's address the duration the on-call provider chose. We can take a poll here, and please think about your answer. Is 10 days of therapy A, too long, B, too short, or C, just right? We recommend a 5 to 7 day course of antibiotics for residents with suspected pneumonia. The most recent guidelines for hospital or ventilator-acquired pneumonia indicate that longer courses of therapy are not superior to shorter courses. Also, 5 days is usually a sufficient length of therapy to treat community-acquired pneumonia. So, 10 days is probably too long in Mary's case, especially if she is improving and appears stable. Remember, a lingering cough and chest X-ray abnormalities may take several weeks to improve. There is no need to prolong antibiotic therapy or repeat imaging if the resident is otherwise showing improvement. The next morning, the daytime provider follows up on her additional diagnostic tests. Her urine strep pneumoniae or pneumococcal antigen is positive. What is the next best step in management? Think about your answers. 1. Should you continue the previous levofloxacin course? No. While levofloxacin will probably work, it is too broad therapy with a known pneumococcal infection and carries many side effects which may be avoided by narrowing her antibiotic therapy. 2. Should you stop levofloxacin and switch to amoxicillin? Yes, this is correct. Amoxicillin specifically targets strep pneumoniae, is a narrower therapy, and has fewer side effects than levofloxacin, so it is clearly the preferred choice. 3. Should you stop all antibiotics? No. As we said before, she has a cough, elevated temperature, leukocytosis, and infiltrate on a chest film. This positive Streptococcus pneumoniae test reveals a bacterial pathogen known to cause pneumonia. The clinical picture is one of bacterial pneumonia, and therefore she should be treated. 4. Should you transfer to the hospital? Also incorrect. There is no indication for transfer to the hospital at this point. Mary is clinically stable, and we can now target our antibiotic therapy to the offending organism due to the smart thinking by her daytime provider to send the additional diagnostic tests. The only correct next step here is to stop levofloxacin and switch to amoxicillin. Remember the alphabet soup of pneumonia diagnoses we started off with at the beginning of this session? Recommendations for healthcare-acquired pneumonia are from an older set of guidelines. Those guidelines called for 7 days of antibiotics, except for cases caused by Pseudomonas, for which 14 days was recommended. More recent guidelines used the terms HAP for hospital-acquired pneumonia and VAP for ventilator-associated pneumonia. For both HAP and VAP, the recommended length of treatment is 7 days, even for people known to have Pseudomonas, as long as the patient shows improvement on therapy. Most cases of CAP, or community-acquired pneumonia, require only 5 days of treatment. Usually after 3 to 4 days of antibiotics and supportive care, people are no longer febrile, have a decreasing white count, and are breathing more comfortably and have an improved appetite. Since we used a rapid diagnostic test, the Streptococcus pneumoniae urinary antigen test, and know the cause of Mary's infection, we also know she has community-acquired pneumonia and should plan on a total of 5 days of antibiotics. Remember, she already received her first dose of levofloxacin, which counts as day 1 of antibiotic therapy. Now that we are switching to amoxicillin, we know she only needs 4 more days of therapy. Finally, when writing for antibiotics, we recommend you to include a calendar-based stop date. So rather than write a prescription for amoxicillin 500 milligrams by mouth 3 times a day for 4 days, instead write for amoxicillin 500 milligrams by mouth 3 times a day to start January 7th and to stop January 10th, which is day 4. While Mary's case looked like it could be treated without transferring her to a hospital, there are some instances where transfer is necessary. If the resident has not shown any clinical improvement within 24 hours of starting antibiotics, or if there is any evidence of clinical instability, which includes inability to maintain oxygen saturation, hypotension, or tachycardia. Let's move on to another case. Francisco is a long-term resident at your facility who has been living there for over 10 years. He has dementia and is bedbound due to a prior stroke. One of the nurses noted that when she was feeding him his applesauce earlier that day, he choked and was coughing afterwards. The evening nurse notes that he is coughing a lot and his oxygen saturations are dropping. Francisco's chest x-ray shows a new consolidation in the right lower lobe. This x-ray pattern is classic for aspiration pneumonia or pneumonitis. We typically see infiltrates on the right because the right mainstem bronchus is shorter with a more direct path to the lungs. If patients are prone when they aspirate, the infiltrate can be in the right upper lobe. While it looks like Francisco is aspirated, it is unclear whether he has pneumonitis or pneumonia at this time. Antibiotics at this time would be considered prophylactic, as he has not developed true pneumonia yet. We do not recommend the prophylactic use of antibiotics in patients in whom aspiration is suspected or witnessed. Despite known recommendations against prophylactic antibiotics, this practice is still quite common, and it can contribute to more rapid development of antibiotic resistance in C. difficile infection, which can have devastating consequences for patients or residents. Let's take a minute to try and distinguish between aspiration pneumonitis and aspiration pneumonia. Aspiration pneumonitis occurs due to inhaling sterile gastric contents into the lungs, which in turn causes inflammation. The inflammation caused by aspiration can lead to changes on chest films, as well as fever and increased white blood cell counts. Aspiration pneumonia typically occurs due to aspiration of bacteria colonizing the oropharyngeal tract, resulting in an inflammatory response to the bacteria itself. Clinical features can be similar between the two, but most importantly, aspiration pneumonitis symptoms should resolve within 48 hours without antibiotic therapy, while pneumonia will persist. While it may be tempting to immediately place a resident on antibiotics after a witnessed aspiration event, guidelines do not recommend this practice. The antibiotic exposure may only select for more resistant organisms in patients who are otherwise suffering from an uncomplicated pneumonitis that will resolve from supportive care and could lead to other complications such as renal injury and C. difficile infection. Prevention of aspiration here is key. Ensuring that the patient is on the proper diet and is positioned properly during eating are absolutely necessary. If a resident has an episode of aspiration or appears at high risk for aspiration, obtaining a speech and swallow examination to confirm they are on the appropriate diet and clarify their risk can help to prevent future aspiration events. Based on our review of these syndromes, what do you suggest for our next best step in management? 1. Start levofloxacin for 10 days. No, this is incorrect. We already learned that duration is too long, and starting a resident on antibiotics simply because they had a witnessed aspiration is not indicated. 2. Obtain a sputum culture, urine Legionella antigen, and urine pneumococcal antigen. It is good to think about diagnostic workup, but may be premature in a resident who we are not even sure has pneumonia. So in this case, it is also incorrect. 3. Transfer to the emergency department. This is premature as well. He is clinically stable and does not appear septic, so we probably do not need to transfer at this time. 4. Place on speech swallow precautions and carefully observe for 48 hours. Yes, this is correct. Careful observation and prevention is very important in cases of suspected aspiration pneumonitis. Empiric antibiotic therapy is appropriate for patients who aspirate gastric contents and who have small bowel obstruction or other conditions associated with colonization of the gastric contents. Antibiotic therapy should be considered for patients with aspiration pneumonitis that fails to resolve within 48 hours after aspiration, as this may suggest a developing pneumonia. We recommend using ampicillin sulbactam or amoxicillin clavulanic acid for residents with aspiration pneumonia, not pneumonitis. This provides aerobic and anaerobic coverage and covers typical organisms found in the oropharyngeal flora. If the patient is penicillin allergic, you can consider using a fluoroquinolone with anaerobic coverage such as moxifloxacin. Let's review some key points. First, remember that appropriate diagnostic testing can help to determine if an infection is present, which can aid in narrowing antibiotic therapy. 5 to 7 days is enough for most diagnoses of pneumonia. And in the event of a witnessed aspiration, we recommend carefully observing the resident prior to starting antibiotics. Disclaimer: the findings and recommendations in this narrated presentation are those of the authors, who are responsible for its content, and do not necessarily represent the views of AHRQ. No statement in this narrated presentation should be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Any practice described in this narrated presentation must be applied by healthcare practitioners in accordance with professional judgment and standards of care in regard to the unique circumstances that may apply in each situation they encounter. These practices are offered as helpful options for consideration by healthcare practitioners, not as guidelines.